Hello, everybody. Our program tonight is digital implant dentistry from scan to guide to final restoration. And we're going to walk through that process here tonight. We'll talk for about 45 minutes, and then at the end, we'll open it up for a question and answer. And so if you think of anything as we go along, make sure and jot it down, and we'll try to address all of those questions. Just a little bit about me. I'm a lab tech originally, went to lab school, and so I have an intimate knowledge of not just the hands-on dental portion of this, but then also the fabrication techniques. We do this process in-house beginning to end, everything that we talk about today. And so we have an in-house CAD/CAM laboratory. Been practicing for the past 14 years, and then been participating in CE courses here since about 2014. I agree with Lisa here. I'd like to start by thanking everybody. Thank you all in attendance. Thank you Implant Direct for sponsoring. And of course, we want to thank the innovators who've gotten us to this point. Pretty amazing stuff today, what we're able to do. So what's the goal? Obviously, to make something amazing happen, there's a lot of pieces that go into that. Planning, here in implant planning, is a complex series of events that have to occur properly to have this very predictable outcome. It's a fine dance, if you will. It's great planning, as in a soccer game here. It's really no different. The level of sophistication is no different. So we'll back up a little bit and we'll just talk a little bit about the progressions of the technologies that have led us to this point. And so early x-rays, panoramic x-rays were around to give practitioners some good information. As time went on, CBCT became available, and now dentists had a lot more information. We had cross-section information. We were able to look at things in much more detail. With that, we were able to make some initial guides, but they weren't so easy. They were kind of clunky. We had to bring patients in. We had to have scan templates. Laboratory expense was involved in all of this, and so it took several extra steps to arrive there. And then as that technology progressed, we have today's guides. That is precisely what we're going to be going through today. So big question, well, why guided surgery? Precision, decreased stress, less chair time, and it's a true restorative driven implant placement. These are all some of the many reasons as to why you would choose to do guided surgery. When we think of guides, a lot of things can be considered a guide. Over the years, I've used a number of things. Sometimes we don't need a true precision guide. Sometimes we just need to get things in a ballpark, and there's ways to do that. Doing a wax up, a suck down template, that can be considered a guide. That's helping you decide where the final restoration is going to go in relation to, say, an implant placement. A denture can be used as a guide, knowing where the final prosthesis, where the teeth belong, what the vertical dimension is. These are all things that can be helpful in deciding where your implants are to be placed. And then you have semi-precision and precision guides. And so semi-precision guide is going to be a guide that's going to be, say, a pilot drill guide. So it's going to allow you to make your initial osteotomy through a guide, and then you'll remove the guide and finish freehand implant placement. Precision guide is going to be full diameter, full length guide. This can stay on through the entire process of the osteotomy. So there's definitely some requirements in doing a precision guide. You have to have certain things, and the most important thing is a true partnership relationship with your dental laboratory. Coming from a lab background, I can't stress that enough, how important it is to have a good relationship with your laboratory. But in this instance, it's even more important because of the level of expertise that's needed here. So a lab that you work with must have experience with surgical planning. They must have experience in 3D printing, and they must have great communication. For a laboratory to get involved with helping planning, obviously this is another level for a laboratory in complexity. You know, asking them to make a crown for us or to do restorative work is one thing, but now when they cross over and become involved surgically, we want to make sure that they're well trained, that they understand structures, and that they understand how to use the machinery that they have available. So we're going to walk through this process step by step. And the first thing that we talk about is our data gathering. So to allow us to do a guide, to do guided surgery, we need a couple of very simple things today. Either an alginate impression, poured up, stone cast, or a scanned arch. If you're intraoral scanning, a scan of the arch is perfect. And then we need CBCT data. And so let's walk through this then. Here's our full arch scan of a lower arch, and we're going to walk through this case step by step. Here's our CBCT data, and this is going to be uploaded. Now I think it's really important that everybody tries to understand these steps that are involved to get to the end product being a surgical guide, an implant that's placed in the ideal position, but to fully understand what's going on and how we arrive at that. Because just like anything, if you send a bad impression in and margins aren't visible to your laboratory, well, the end product is going to be questionable. This is no different. If the CBCT isn't ideal, if you're not calibrating your units regularly, if the patient isn't still for the image, softwares can only do so much to compensate for scatter, for some of these things. So the more precise we can be, the better we can feel about the precision of our guide at the end of the day. So once we have the data in the laboratory, what happens is we merge the data. And this is one of the more interesting things here, and this is one of the biggest innovations. Again, as I mentioned before, in the past, to fabricate a guide, it required several additional steps. You had to create a stent or a denture, and that would have to be scanned in the patient's mouth. What that would do then is that would orient the guide markers to the bony structure. With the softwares today, we're able to merge the data from the CT and that stone model or scan. We're able to merge that together without having to make any additional appliances. Once that merge is done, now you're merging soft tissue, hard tissue. You're able to see everything essentially. This is what it looks like. So cone beams have gotten better and better as time has gone on, to where they're able to give us some tooth structure, some accurate tooth structure. And when that's merged with that stone model or scan, you're able to accurately merge that And so this screen shows very clearly what you're looking at. You're seeing the teeth. We're seeing soft tissue in that cast. And then, of course, the laboratory in this planning software, we're able to bring in the bone and see the bone as well. So mapping is what's done next. And so we're able to map things out, map the sinus, map the nerve, and map out adjacent roots. And so now the software allows us to go through a process. In this case, we're looking at a lower. It allows us the opportunity to map out critical structures and walk through and map out the nerve. And this is important, obviously, because as we continue planning this implant, we want to know precisely where these structures are. In freehand surgery, you're able to take measurements and work off of those measurements. But of course here, this is another level of sophistication in that you're able to create a guide that will prevent you from going anywhere near the nerve in this particular case. There we go. So next, we're able to actually perform the surgery digitally. So digital surgery is placing our implant in all 3 dimensions. Again, with that data merge, we're now able to see all the structures: soft tissue, hard tissue, bone. And so now software allows us to pick implant size. And so this, again, is where communication between doctor and lab is so critical, in that what brand of implant we use, what your typical size, what you would hope to achieve on a case like this, what diameter implant, what length implant you prefer, this is all important. And so in this case, we're going through our implant selection, our typical posterior implant, somewhere between 4.2 millimeters up to 5.7. That's generally the range we would work in. In this particular case, we opted for a 4.7 by 10 Implant Direct Legacy implant. And so again, implant selection based on whichever brand we're dealing with. Here we're dealing with Implant Direct. We have the entire library of implants, and these are accurate representations of the real implants that you'll see moving forward in the next steps. So here we are. Now we're able to place our implant in all dimensions. Obviously, in viewing a cone beam, you have all of these views. You're going to have a panoramic view we see on the lower left, cross-section views, sagittal views. We have all of these different views, and we're able to place the implant in all of those dimensions. We're able to see that placement on the software as to where our screw access hole is going to come out of the tooth. These are all things that are so helpful in implant dentistry. When we're looking intraorally, what sometimes appears to be centered or appears to be following a particular trajectory really isn't. And I think if you've placed many implants, you'll see radiographs after placement where you thought you were parallel with the adjacent tooth, and the radiograph shows you you weren't. I've placed a couple of thousand implants, and I know that I've caught myself a couple of times afterwards saying, that's not what I expected. Some of these structures are just not obvious, and angulation is very tricky in the mouth. In this environment, it's 100% controlled. So angulation can be looked at in a near perfect setting without some of the distractions we have during surgery. So Here's some of our alignment views, our cross-section view, our sagittal view. Another big benefit of softwares are that when we mark these critical structures, so if we look at the left picture here, we can see the IA nerve, which has been mapped out. We can see the implant, but then surrounding the implant is this safety zone. The software won't allow you to place the implant around a marked structure within that 2 millimeters. It won't let you place it within a adjacent root within 2 millimeters. And so there's definitely some safety involved in this as well. So now the laboratory has gone through the steps and they've proposed a treatment here. They've helped plan a surgery. Now everything is sent to the doctor for adjustments or final approval. Obviously, this is not in every laboratory scope. As we talked about earlier, the importance of good communication with your laboratory is critical, but this is within many laboratory scope. And so having this communication for them to understand what that end result should look like, you need to be involved in that process with them. Many of the softwares, we are looking at 3Shape software is what we are using right here, Implant Studio, and many of the softwares, this one included, requires the doctor to make a final approval before we can move on to guide fabrication. And so now once we know where the implant is going, guide fabrication is relatively straightforward. Again, since we've merged the data from our scan or model, we have a very accurate tooth representation, something that you would feel comfortable making a night guard to fit on or an Essex retainer to fit on. So we would trust the accuracy of that scan or model. In the same way, we can trust our guide to fit the same. So guide design, relatively straightforward. Software walks us through undercuts and retention and so forth. Once we have a guide design, now the software will put out a drilling protocol. This is the recipe. So this is what will get delivered with the guide to the end user, to the doctor, to place the implant. And it's going to give you all of your information. First, what we look at here down on the bottom is going to talk about what we call sleeve offset, some numbers here, which will be important, where our implant is going in relation to the teeth, drill length, and again, it'll go through the drill protocol. This is the second part that comes along with that drill protocol. And so it's going to give us some very basic information: tooth number, manufacturer, type of implant, length, diameter, sleeve information, the drill length that's going to be necessary, offset. So these are parts that will be needed. And again, the laboratory generally will provide everything except for the drills that you would have. And so again, we call that drill protocol the recipe. It gives you your final report on many of these factors. So before the patient ever sets foot in the office for surgery, we already know what implant we're using, what the drill sequence is going to be. That's all been figured out. So once that design is complete, we send that over to our 3D printer. 3D printing is amazing today for these applications. This is really the main application we use our printer for. FORMLABS is a very cost-effective printer, not very, very fast. Takes about 3 to 4 hours to print out models. You could print 10 to 12 at a time with something like this. But you get a very accurate print in a very cost-effective way. So this is the raw print as it's being printed on the right. Once that's complete, we clean it up, we sterilize it, we insert the sleeve. So when we looked at that drilling protocol, it had something called a G sleeve. That is the metal sleeve which is in the guide at this point. And so this material is sterilizable. So we can sterilize this. This is ready to go in. So always cool to see concept to final product. And that's what we're looking at here. So guide placement. Now this is a test to how good our original data was, our scan or our alginate. You know, we have to ensure good fit of the guide. The guide should fit intimately with all teeth. The guide should be stable. There should be no rocking. Much like, again, an Essex or a night guard, we should expect a very similar fit. Now that we have a guide, now we can move into the surgery now. The first thing that we'll show here is the Implant Direct Key Kit for the guided surgery. And so what a key kit is a series of instruments which fit into the guide, which allows the drills to step through incrementally to create the final osteotomy. So we have our guide, and here is one of the keys in the guide on our day of surgery, just to demonstrate how that fit is. The walls of that guide, of that G sleeve, excuse me, that metal sleeve, they're parallel. And so the fit of that key is very intimate. There is no rocking, there is no movement here. So the keys correspond to each drill in the sequence, and they're marked accordingly. Everything is color-coded with Implant Direct, which makes it very nice. The keys are precision fit to the metal sleeve of the guide. The implant osteotomy burrs are precision fit to the key. So again, there's very little to no slop. Here's all three of those pieces together. So you have your osteotomy drill. It's not in perfect focus here. You've got your instrument, key, and you've got your guide. So all three pieces are fit for demonstration purposes here. In the mouth, this is what it looks like. Guide in place, and the guide fits retentively. Again, the software has the ability to see height of contour on the teeth to create enough friction for this to fit. Obviously, there's some parameters. You have to have enough teeth to get a stable fit. There are other techniques that are based off of soft tissue, but for the most basic guides like this, they're tooth-borne guides. I'm going to play a short video here that goes through that key kit. It's a little hard to fully understand the key kit by seeing a couple of slides, but this is a short video, a couple of minutes, that walks through this. Implant Direct has this available. And this will really help understand, put this visually as it goes. Very good. So I hope that helped understand step by step how that works. And so, again, what the drill protocol gives you is some of those offset numbers to know the height of where those drills will go to bottom out, if you will, with that sleeve. And each step in the key kit incrementally corresponds to a larger drill to arrive at your final osteotomy. Very good. So back to our case now. Here is the initial implant placement. So again, as we walk through this case, we started with initial data, a plan, a guide to achieve the plan, and now we have our implant placed. And so if we look at this again, now we have conceptual implant placement on the left and the real thing on the right. And it's pretty amazing because, again, the level of precision makes this such that a surgery day is not a stressful situation. You can feel very comfortable that with the right planning, with the right data, you're going to get that implant in an ideal position. To do this freehand, again, it's possible, but there is a good deal more stress involved in achieving that. So now our implant's in position, implant's healed, and it's time to impression. Following through this digital protocol, we're going to go through this process in the pure digital workflow, which is scanning that implant. So now we're scanning with scan adapters. These are all provided by Implant Direct, available by Implant Direct. We're a 3Shape office, so we like 3Shape for our planning software. We like them for our scanning hardware, and so we use the 3Shape scanner. And so here's our trio scan of the scan body. And so again, get into a little bit more of the lab terminology. You know, what the scanned implant does is essentially what a soft tissue model would do. But when you think of accuracy and you think of steps, you're really reducing a great number of steps with the scanner. So if you think of old workflow to create the screw retained crown, we would have to take an impression of a transfer. That would go to the laboratory. Laboratory would have to pour that up with a tissue material with a lab analog to create a model of the implant. And then from there, either they would scan to make you a custom abutment, or they would wax up an abutment, or they would choose an abutment or a tie base, and then they could fabricate the crown. This eliminates so many of those steps. You're scanning the soft tissue profile, you're scanning the scan adapter, and you're presenting the lab then with implant positioning. So again, we think of scanning, we're scanning the working side, the opposing side, the bite. We're scanning the tissue profile with the healing abutment removed, and then we're scanning that scan adapter. So we use 3Shape software as well to fabricate our crowns, but now you have everything once again. You have your implant and you have your final restoration all planned here. And now again, we go from the original concept to the final restoration. As I said, this can all be done in a relatively easy way compared to ways of past. And that's, I say, the technology today has really simplified this to where there are far fewer steps involved in going from implant to final restoration in the most predictable way and in the least stressful way. This is a screw retained restoration, and with the proper planning, you can achieve that on nearly every case. The troubles you get into with implant placement, by and large, can be avoided using guides. So I can't say enough about the technology, can't say enough about the simplicity to arrive at this. As I said, some of the most important things to consider are relationships with laboratory. You have to have good partners to get you to this point, to get you to that predictable outcome, partners that you can trust to help you with the planning. It's not that you couldn't do this in office. You certainly could, but it is an investment in hardware and software and in your time. And so some dentists that are very, very hands-on that would prefer to do it certainly can. It requires having 3Shape Implant Studio software. It would require having a 3Shape scanner. It would require having Implant Direct libraries or your implant company's libraries uploaded to all of that. And it would require a 3D printer and of course, again, a good deal of your time. And so it is very possible to do in office, but I think for most people, finding a good laboratory to help with it is the most reasonable way to accomplish this. So we finished up pretty much on time here as far as the presentation goes. We want to open it up now for questions. Hopefully we have some good questions. It's a lot of information to go through. And we're going to open it up here and hopefully answer some of your questions. Okay, so here's a good, interesting question. Can the laboratory design the surgical guide and you print the guide in the office? Absolutely. And again, I think with the coordination with your laboratory, that's certainly possible. You know, in the with my consideration of lab background, I really see that that's the way a lot of things will move as time goes on, that laboratories will be more involved in designing and offices can actually put out the product. That saves a lot of time delivering products back and forth. So certainly it is possible. Again, it's about having the relationship with the laboratory to allow that to happen. Got another question here. Can we use any other software to design the guide for Implant Direct? Answer is yes. You just have to have a software that is compatible in that they allow you to upload libraries for Implant Direct. There's many third-party softwares out there. which do allow you to do that. I don't know all of them, but I imagine ones like Anatomage and Vivo, all of the major planning softwares generally today have worked with all of the implant manufacturers to make that available. Let's see here. Another question here. Okay. How do we get the implant guide protocol? How does the lab know how tall the guide sleeve handle is? They know because as they're picking that sleeve, the sleeve is specific to Implant Direct. And so when they pick the implant from the software, they're given in that protocol they're given the information on that sleeve. Got another good one here. What is the cost of fabricating the surgical guide and software cost? Cost of fabricating the guide depends on who's fabricating it. If you're fabricating it in office, the raw material cost on the printer is like $5, and that's what FORMLABS says, and that's pretty accurate. Of course, there's other parts that go along with that. A laboratory will generally charge you somewhere from $300 to $400 to provide that service. Now, that may include multiple things, though. The laboratory will do the initial planning. They will have bought the software and fabricated the guide, cleaned the guide up. So there's many things that go into that. But the raw material cost to fabricate a guide is roughly $5. The sleeve from Implant Direct, I believe, costs $10 or $15. And so that is your true raw material cost. The software cost, the 3Shape Implant Studio, is several $1,000s, and it has to be renewed yearly. My experience with some of the softwares, we're pretty loyal to 3Shape. We take no funds from them. We don't speak on their behalf, but they seem to be the industry leader in many of their softwares, and so we have their suite of softwares. They are expensive, and they do come with yearly renewal fees, but I want to say that it's roughly $3,000 to $4,000 for the software, and so you have to do enough of them to justify it if you're going to buy the software. And so somebody was asking about the process being more focused on bone-driven versus prosto-driven. There's no doubt in freehand surgery it is mostly bone-driven. In guided surgery like this, the final product can be conceptualized before it's ever been fabricated. So before an implant plan is ever made, you can see what parameters you're dealing with. The software will allow you, if you wanted to design a crown before you even look at placing an implant, to know what the emergence would look like to the crown design, which would be your prosthodontically driven outcome. So there's no doubt with guided, it's definitely far more pros-driven, because as you start moving along through that guide process, you see angulation, so you see your screw access hole. You're able to see much more than doing a true non-guided surgery, a freehand surgery. Got a question about the accuracy level is there a micron accuracy or level of accuracy to the CDCT? And so that is a hard question for me. I don't know the technicalities of that. What I do know is that the newer the cone beam, the more accurate the images are. So we've been, in our group, we have a couple of different cone beams, and our newest cone beams are definitely easier to merge the data with. And so from that, we know it's more accurate. And so what that micron accuracy is, I couldn't tell you. I'm sure the companies do know that. But again, it just depends on what you're looking at. In my mind, you know, one of the beauties I look at with dental implants, I'm place a lot of implants, a big implant practitioner, and one of the things I really like about it is that we're dealing in millimeters and not half a millimeters or a quarter of a millimeters like in something like endo, which is a much more precision-based discipline in dentistry. In implants, we're dealing in millimeters generally, and so to have this 2 millimeter safety zone is very, very beneficial. Now, you know, to a beginning practitioner, certainly you have to get a trust level with the guides that you're receiving. And so I would absolutely recommend not trusting them 100% and using the guide to perhaps make your initial osteotomy, but then take the guide off and raise the flap and look at it. And there's absolutely nothing wrong with taking radiographs through the process to verify that the plan and the guide are accurate. And so there are still many steps to be taken if you choose to. Once you're comfortable with it, once you're comfortable with the workflow and comfortable with the results that you've been able to get, well, then you certainly can trust the guide. This case was done purely guided, no flap raised, so just straight through the tissue, literally a 5-minute surgery. But I've had a good deal of experience with the guides. I didn't do that on my first guide. I didn't trust the guides, and I would recommend to not ultimately. The technology is wonderful, but again, there's many things that have to go perfectly right to arrive at that final result. So there's a question about fixing surgical stent to a completely edentulous patient. That is a different lecture for sure. It is a little bit more complicated of a workflow, and certainly a little more complex to explain in this setting. So I can't address that one with this. Next one, do you find any benefits placing implants through the guide? Not necessarily. There's a level of precision that you could get to where you could potentially manufacture the final restoration at the same time that you're manufacturing the guide. In that scenario, placing through the guide to get the implant hex placed exactly where you need it is possible. My opinion is that, again, it's just a little too much to expect to perfect at that level. I don't personally do that. I don't make the final restoration at the same time that I make the guide. We let everything heal, and then we're going to scan the implant. So potentially you could cut out even more steps, but at this point I don't. So I don't place through the guide. I remove the guide and I place freehand into the osteotomy that was created with the guide. A question here about the drill markings on implant direct drills. And that's difficult. I've worked with multiple kits, And there's pros and cons with the drill kit through Implant Direct. Obviously, the pro is less drills are necessary. The con is that you have to have sharp markings and a good fix on those markings consistently. And that does come with experience too. So the longer you work with them, the more you'll feel more comfortable with it. Early on, for my first hundreds of implants, I kept a metal endo ruler in my surgical box, and I constantly went back and forth to measure those markings. And then the other thing too is that you do have to change those drills out over time as they get sterilized. The drills aren't as sharp color, they fade in color, the markings fade as well, and so there is the need to change those out at regular intervals. Question is, do you recommend any other printer besides the printer showed? I have only worked with FORMLABS printer. I hear great things about carbon printer, which is a very hot topic now. The difference is, I don't know exactly the carbon cost, but it's expensive. A FORMLABS printer is a very entry-level printer, $2,500, a few other bells and whistles, but you can have a printer in your office for roughly $3,000. A carbon printer is made for manufacturing, large-scale laboratory, and they're quite expensive. So I haven't worked with any. We've been interested. We go to Lab Day in Chicago almost every year and see what's out there and see what's on the horizon. But no, I don't have any other experience with the others, so I can't recommend. Okay, is there a depth limiting feature that could be used with the surgical guide? I'm assuming that is to know for sure, to control your depth. There is not. I've seen different kits out there that do allow you to put stops on drills. I haven't used them, but I've seen stops that could be used on particular drills, and that stop essentially would be screwed in. It's a metal sleeve that gets tightened to the drill, and in using something like that, that would essentially bottom the drill out. Next question is about Zimmer drills. Can I use my Zimmer drills to place legacy implants? You certainly could. I don't know that they line up exactly for the sake of the surgical guide. And so that I couldn't tell you. If you were doing freehand surgery, I don't think there's any issue there. And the reality is, with an osteotomy drill, when you're drilling your final drill for, say, a 4.7 millimeter implant, you're not using a 4.7 millimeter drill. Your drill, I believe, is 4.4 millimeters in diameter. And so you're always slightly undersizing your osteotomies. And so the precision of that is give or take X amount for your implant to go into that hole. The only thing I don't know is if the Zimmer drills would be compatible with the sleeve that is purchased through Implant Direct. So that would be the only thing that I don't know the answer to. So next question is, don't understand, when will I have to use the spacers? Okay, so when you think of the slide or the video that showed the use of those spacers in the key kit, it all depends on what your final implant diameter is. So if your final implant diameter ends in the green range, so a 3.7 millimeter implant rather, I believe that is the cutoff in the key kit where the laboratory will put a small metal sleeve in your guide, and so you wouldn't have to use any spacers. If your final implant diameter is going to be larger, if it's a 4/7, a 5/7, now you're going to have the large metal sleeve in the guide, but you're going to still have to use the small keys for the first steps of the osteotomy, and that's why you have to use a spacer. So it all has to do with your final implant diameter. If you're using a more narrow final implant, then you won't need spacers. If you're using a larger final implant diameter, then you'll need the spacers for the first few drills, but not for the final drills. Next is, does the company partner with dental lab who fabricate surgical guides? Not necessarily. Implant companies don't, but generally your rep should have some recommendations. So generally implant reps that are out there know dentists, they know laboratories, and so they help create those networks for you. You have to do a little research, certainly talk to your current labs. Some of them do this, and you may not know that they do this. Some of the bigger labs may do this as well, and so you have a few different options to look at there. But first of all, I would start with your rep, because your rep is out there and should know some of these local labs. Next question, when you use guides for your implant surgery, do you open a flap, tissue, or do I tissue punch typically? As I said before, it's case by case, and it's along your comfort level with the guides. At first, I raised the flap because, as I said, I didn't necessarily trust the guide. And so I had to gain a level of comfort to say, yes, I trust these completely now. So for the first several guides I did, I flapped. I wanted to see the osteotomy. I wanted to physically be able to see that the plan on the guide was accurate. But now that I've done this enough, I have a comfort level to say, now I can just tissue punch. And by tissue punch, I mean I do nothing. I don't go in there with a physical tissue punch. I go straight through the tissue with the drill, and that's it. Next question is, what is the typical interocclusal distance needed for a surgical stent? It's not much. The thickness of the stent itself is roughly 2 to 3 millimeters thick. So the material that the software will automatically design is roughly 2 to 3 millimeters thick. The part that can increase the height is based on the diameter, so the mesial distal space between the teeth and where that sleeve has to go. If it's a very narrow space, then that sleeve is going to have to go higher, and you're going to need a greater interocclusal space. But if the space is, hard to explain this, but a typical space, so not a narrow space, then your sleeve should fit in the space, and the interocclusal space is going to be very minimal, 2 to 3 millimeters. Next question here. Once the guide is made, can the choice to the site be made and still, like this says, still maintain accuracy? In this, you wouldn't change. So once the guide is made, you could decide whether or not you want to flap or not. That wouldn't change anything. But your drill protocol is all predetermined, so you wouldn't want to change. You wouldn't want to change diameters. You certainly could. So certainly, if you decided that the density of the bone wasn't what you thought, and you create your osteotomy and you feel that the bone is quite soft, and you want to place a larger diameter implant into that softer bone, as long as you know you have the space to move more to like a freehand surgery, you certainly can. So there isn't anything locking you into to the guide. It's a tool, of course, to help you get to an end result. And again, if everything is ideal, if the plan is ideal, the bone is ideal, if all of these things are ideal, then there isn't need, but it is very helpful to have the flexibility to understand freehand surgery, because things do happen in the middle of a surgery. Things may change, and it is very important to have some flexibility to move and change your plan as needed. Next question here is, what do we need to buy besides the keys to incorporate guided surgery? That would really be the only thing. So you need a key kit, you need a laboratory, you don't necessarily need an intraoral scanner. Again, an alginate will do. And then you need a CT scan. So if you can provide your laboratory with the DICOM from the CT scan, if you can provide them with the alginate or the model, then all you really need is the key kit. Next question is the implant placed through the guide sleeve? And if so, how do you visualize the final depth, final rotation and depth? And so you can do either. You can place it through the sleeve, or you don't need to. My personal preference is to not place it through the sleeve because I want to look at it myself. It is almost impossible to gauge the depth as you're placing it through that guide, and you still have tools placing it through the guide to show you where the hex is, but it's far easier to do it freehand, to be looking at it as you do it. Understand, again, osteotomy drills are accurate, but they're not necessarily corresponding exactly to your implant size. Implant osteotomy drills are actually longer, so your 10mm notch on your drill is actually longer than 10mm. So they're actually making room for any bone compression to occur at the apex. And so they're precise to that sleeve, but they're not necessarily precise. Bone is not solid. It definitely moves. And so you have some flexibility there. So my preference, once again, is to not place through the guide and to manually place it and see that implant, see the bone height, and see that hex. Do you have windows placed in the guide for proper placement? Yes, I do prefer windows on the guide. That particular example did not have windows. And so windows essentially are cutouts on the guide to allow you to look at the teeth below the guide to see the intimacy of the fit. And so windows are beneficial, but not 100% necessary either. So it just depends on preference. My recommendation is to have a couple of windows made in the guide so you can physically see. Obviously, there's a couple of ways to evaluate your fit of your guide. Once again, the fit should be a very solid fit. You should have no rocking. You shouldn't have any moving. It should stay on once it's placed on. So there should be undercut enough that it engages. So it's not coming on and off. And guide or windows into the guide are one way, another way to allow you to see that. Very good. It looks like we've cleared all of the questions here. Certainly, my email is here. Certainly feel free to email with any additional questions. Be happy to share. Hope you all got a good intro here to understanding guides and seeing the step-by-step process. Like I say, I think this really takes a lot of the stress out of a surgery, especially on a healed site, makes this very predictable. It's a great entryway into implant dentistry because once again, you get a lot more tools to evaluate where you're going. Thank you guys for hanging around. Thanks for the attention, and hope to hear from you guys.